Hi, welcome to Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's great to be with you again. It's springtime, spring is in the air, flowers are in bloom, the weather's getting warmer and warmer. It's even hot here in Florida as usual. We just finished March Madness, and it's a perfect time to learn more information and improve our skills. I have a wonderful guest with me today, and I look forward to discussing a very interesting case. In fact, if you just paid attention to this introduction, I gave you a little clue subtly about what this case is about. Sit back and enjoy. Well, welcome to Lessons from the Lab. It's a wonderful spring day, and I have a wonderful guest with me today, Dr. Michelle Maurerman. Dr. Maurerman's a professor of neurology at Mayo Clinic way up north in Rochester, Minnesota. Hi, Michelle.
Hi, how are you, Devin?
I'm good. How are you?
Oh, pretty good. I'm just I'm kind of feeling sad about the way the championship for the basketball game went last night.
Oh,
I'm
yeah.
sure you're feeling the opposite.
Well, I kind of am, but I'm in Florida, but I didn't grow up here. So I'm one of
Okay.
those people that if they lose, I don't lose sleep over it. So
Yeah.
yeah.
I I'm only sad because we had our EMG lab pool bracket and
Oh,
I was
okay.
going to win had Houston won.
Oh, okay. Well,
And
what
instead,
would you have won?
like $250.
Oh, so there's real money. Yeah,
Yeah, I mean there was enough people in it that, it was something. And
yeah.
my son was going to be in second. And so he just sobbed last night when they lost at the end because he was like, I was going to be in second and he would have gotten a share of the winnings as second
Yeah.
place.
Now, did you have help filling out your bracket?
I just kind of like,
Yeah.
wasn't real. The only thing I was like, okay, the odds for like six playing 10 or whatever it is like the worst. So that was where I like picked some upsets and things.
Yeah.
Otherwise,
Yeah. Well, it's fun.
yeah.
We do a family one and it's
Oh,
makes
that's
it
cool.
fun. So the big thing is no one wants to come in last. So as long as
Yeah,
you're not last, then it's okay. So
that's okay. Yeah. No, it was fun. It makes it fun.
yeah, it's a fun thing. And we're going to have our own little version of March Madness here, you and me, with no brackets here, but
Yeah.
a crazy case that I want to present to you.
All right.
So
Sounds good.
it's a good springtime case. I know it's spring here in Florida. It's starting to get summer. It's already 90 and
Oh
in
my God.
Rochester, is it still snowing or not yet?
No, it's up and down though. We've had like almost 80 and we've had like 20. So it's
Okay.
typical spring.
So typical spring, and same with us, typical spring summer right away.
Yeah.
So well, anyway, I appreciate you taking the time. As you know, what one of the goals of this educational series is for us to discuss a practical approach to patients that come into the lab. And I had a patient that we saw a few weeks ago. It was pretty recent that I thought was interesting and had some interesting points. And I thought I would share it with you and pick your brain and see how you would approach this patient.
Sure.
So, um, so let's get to it. Let me just
Okay.
I'm going to share my screen and I'll show you a few slides here. So let's see. Can you see my slide there?
Yep. Now I can.
Okay, I'm going to read it just for people who are listening on podcast. I'll just present the case.
Okay.
So basically, it was a fairly straightforward story. It was a 59-year-old healthy woman. She just had hypertension, but no other medical problems, who presented with numbness in her hands and her feet. And her story basically started back almost 10 years ago, about 2016, when she developed numbness in her both hands and her wrist, she said. She
Okay.
described it as a decrease in feeling numbness, so a loss of sensation. And I didn't have the details of her evaluation at that time, but she was diagnosed with carpal tunnel syndrome and ulnar neuropathy and underwent surgery for both of those, but had no improvement. So
Okay.
continued to have numbness. And then over the course of about 8 years, so up until now, the symptoms continued and worsened and extended to her legs. So she started having similar symptoms, loss of feeling and tingling in her feet and it extended up to about her thighs. And she continued to have the hand sensory symptoms. And then she also had this unusual feeling of sort of a tight band, and she called it a numbness around her abdomen as well, which was the only other area that was seemed to be affected. She felt unsteady when standing and walking, and she felt subjectively that she had a generalized decline of strength, but she didn't have foot drop or anything focal that she was aware of. And that was basically it. She was only on blood pressure medicine. She didn't drink alcohol, no, nothing unusual, no drug use. And that was her story. And so when we saw her, and I'll ask you some questions in a moment, but when we examined her, her motor exam was normal. She had completely normal strength. She was hyporeflexic in her arms and areflexic in the legs. And she had sensory loss to all modalities distally in her hands and feet. And to her legs, her pinprick gradient was about just to below the knees.
Okay.
Nothing obvious on the abdomen objectively.
Okay.
So I imagine you've probably seen patients like this.
Yeah, no, definitely. Yeah, some things I guess that come to mind, kind of just hearing the case initially. Just someone who's had carpal tunnel question years before other symptoms. I'm kind of sometimes thinking about like an amyloid kind of situation, like hereditary amyloid, when I think about carpal tunnel years before other symptoms. Um, Symptoms with numbness, hands kind of before feet. I'm also thinking, okay, is this all just neuropathy? Are we missing some kind of cervical myelopathy as contributing to the symptoms? Um, Other kind of neuropathies that start more hands and feet at the same time, some toxic neuropathies, but we don't really have any good history for that. And then the slow progression following that doesn't fit very well. But that might come to mind too, like some of the chemotherapies or alcohol that you mentioned and things like that. Um, the other that this has remained sensory predominant. I'm also thinking just about some of the genetic neuropathies, just very slowly progressive, confined to sensation outside of just TTR, but some of the CMT2 maybe, or HSAN, hereditary sensory and autonomic, or Charcot-Marie-Tooth axonal variety, maybe have that kind of situation. The numbness around the abdomen is interesting. There are reports that amyloid, like transthyretin or AL amyloid, can have this subjective feeling of sensory loss around the abdomen. So that's something to think about. Diabetes, if the patient was diabetic, this sensory loss around the abdomen. Sometimes you can see that feeling of a tight band, that thoracic radiculopathy. But usually that's more occurring in the patients who have like the diabetic lumbosacral radiculoplexus neuropathies or the cervical variety of that, where they're more subacute, painful, onset with pain and weakness. So that doesn't fit that part very well.
Yeah, that's what I was going to say. Usually, in my experience, there's more pain, and she didn't really have any pain.
Mm-hmm.
So it sounds like the hands first
Mm-hmm.
bothers you a little. I mean, it's
It's
if I'm
not your
understanding what you're
typical,
saying, it's not typical of a length-dependent neuropathy, whether it's two different things or
right?
yeah, yeah.
And certainly people who have, length dependent neuropathy may, from diabetes or other causes are more prone to just your garden variety compressive neuropathies. So maybe it's just that in the situation of a um, typical length dependent process. The other thing I think, this global decreased reflexes, areflexia, sensory predominant, you kind of wonder about a sensory polyradiculopathy too.
Mhm. Okay. How, just going back for a second to
Mhm.
your thought on the amyloid, the
Yeah.
TTR amyloid, how often do they get ulnar neuropathy? If indeed she had an ulnar neuropathy, which we don't know.
Yeah, right.
Is that typical? Is
That
that
would be more uncommon. I mean, that's not the typical history. Carpal tunnel, I think just because of the deposition in the tissues around that area, much more common. Just
Mhm.
don't hear about the ulnar as often. I don't know of a number that's been reported, but not
Right.
typical in the literature.
And I think the other point that we both know,
Mhm.
but it's important to mention is, patients with carpal tunnel syndrome can have numbness in their fourth and fifth digits. So just because they had numbness in those fingers doesn't mean it's an ulnar neuropathy, right?
Yes. And I would say we've probably both seen patients who go for carpal tunnel and ulnar nerve transpositions at the same time, not necessarily clear there's a good indication for both
Right.
of them.
Right, exactly. So, okay. So good. Well, good thoughts. Those are some of the things I was thinking of when things were going through my mind as well. So I know we both work at Mayo Clinic. We're both in the Mayo labs, and our labs at different sites are very similar, have similar approaches. But I'm going to ask you anyway.
Yeah.
So, if this patient showed up in the EMG lab, what would you suggest to the approach be? What test would you do?
Yeah, so I think with symptoms in the upper and the lower extremity, you'd want to do nerve conduction studies in the upper and the lower extremity. Um, if it looks by the exam, it's pretty symmetric, so I would probably start with either what was the more symptomatic side for the patient. Looks like none of it is so severe that I wouldn't get any responses. I mean, if the neuropathy was really bad and it was asymmetric, I might pick the side that was a little bit less effective just because I want to get some nerve conduction studies that have some responses to be able to judge the underlying pathophysiology from. I don't think that's a problem here. So for what would my approach be? She's 59, so I would probably do a Searle with conduction. So A, B, and C point. I would do fibular and tibial motor nerve conduction studies. And since it's a neuropathy, I would like to do F waves so I could get some sense about proximal conduction. In the upper limb, because of this history of carpal tunnel release and ulnar nerve transposition, I wouldn't limit myself to what sometimes is our protocol, which is just an ulnar motor median anti. I'd probably want to do both ulnar and median motor and sensory conductions of some sort. And given the release, probably we need antidromics rather than Palmer's, but um,
Yeah.
that
That,
would be my guess that there's enough sensory loss that Palmer's would probably not, orthodromic studies would not give us, good responses.
right. If you're like me, when you get these patients and they've had the surgeries, you think, oh gosh, what am I going to get into? They've had surgeries. How am I going to interpret these findings?
Right.
So those are one of those cases where it's like this is not going to be a straightforward case.
Right. And you may need to do a little more rather than, your minimum kind of amount to say, find a neuropathy.
Yeah. Right. Right. Okay. So so we talked about March Madness. This is going to be like going through brackets here. I'm going to
Okay.
show
Okay.
you, we'll go through some of these conduction studies. This is round
Hmm.
one. And maybe just we can comment on, I'll stop or we can comment on what you think or what you note. Um,
Okay.
so, so we started in the leg
Hmm.
and here's the left fibular. And I'll just mention for those who are listening, the distal latency is 9.9 milliseconds, the amplitude is 0.5, and the velocity is 34 meters per second.
So the amplitude is low, so it's less than a millivolt. So there is some slowing of conduction velocity. The distal latency is pretty prolonged, but we just have to kind of think about that in the situation that the amplitude's pretty low. So we only have a few axons that are kind of conducting. So we may just be seeing the slower one. So we have to be careful about calling it primary demyelination, but we're going to kind of keep that in mind. The waveforms don't show any evidence of conduction block or significant temporal dispersion, I don't think.
Yeah. And for those of you who are viewing it, you see this big positivity here at the knee, which is a common thing in the fibular. It's just volume conduction from some of those distal fibular muscles. So it's not really, I don't know, would you call that to truly dispersed? It has this little bump, but
Yeah, probably
so
not
low.
enough to
Yeah, it's
me.
so low, right?
It's so low in amplitude, I'd be a little careful.
Yeah. Would you do F waves on this patient for the fibular?
Probably going to be absent. I mean, I would try maybe, but likelihood is they're probably going to be absent.
Yeah, I don't think our techs tried on this one
Mhm.
because that was so low. So here's the tibial motor.
Yeah,
Latent.
so
Yeah, go
this is
ahead.
interesting, right? Because we've got a more normal amplitude. Again, no evidence of conduction block. We don't have that problem with the volume conduction here because we have a better response. So we're not seeing that. The velocity is just a tiny bit slow. But what's more interesting is that the distal latency is prolonged here. And that probably is significant in the setting of this more normal amplitude.
Yeah, and it's 7.5 milliseconds. And just that was one thing that sort of
Mhm.
struck me. If you know that I'm going to go back, the fibular latency is 9.9. And if you think about, when I think about all the length dependent neuropathies, the hundreds that we've seen, how often, even with low amplitudes, how
Yeah.
often do you get a latency of about 10 and the fibula
No, I think that's
7.5?
unusual.
Yeah,
Yeah. I mean, I want to tuck it away, but I agree. It's not common that we would just say, oh, it's related to the amplitude. I think with all of the axonal neuropathies, we're still usually seeing more normal latencies.
right. Yeah, which is always interesting because you think it's a
Hmm.
length dependent process. So the very end of the nerve should be affected. So that should be most slowed. But you're right.
Hmm.
We don't, the latencies in the feet are usually
Yeah.
not that bad.
Hmm.
So, okay. So we did do F waves here.
Okay.
Those look pretty
Okay.
good.
Yeah.
Not
Pretty
prolonged compared to F estimate and right.
agreed.
And then we did a Searle
Mhm.
and she's 59.
And so her Searle is probably relatively low. We think, at least in our lab, the quote normals are if you're less than 60, it should be greater or equal to like 6. So we know there's probably a range of what is quote normal, but that's our laboratory normal. So this is low. Again, the velocity here looks normal, as does the latency. And the waveforms look good.
Okay. Our techs will be happy to hear that you said the waveforms look good.
I think they did a
I
great
don't
job
always
trying to
tell
get
them that,
that.
but they're
Yeah.
reliable. Okay. And then we went up to the arm. So this is bracket 2 here. So what do you think about this? This is the median antidromic.
Yeah, so at the distal site, at the wrist, the amplitude is low and the latency is long. So this is hard. It could be going with what we're finding in the leg, that there's prolongation of distal latencies, but this could also be related to this prior history of questionable median neuropathy at the wrist for which they had decompression. So um, the amplitude is so low at the wrist, we're not getting a response at the elbow. I think that's not unexpected, given the low amplitude.
Do you think that's a real response at the wrist?
Oh, it is very broad. You're right.
Well, this came up because I did present this
Yeah.
our techs at our tech teaching conference, and I asked
Hmm.
them, and I had them raise their hand, and they were shy about raising their hand because they weren't sure. But
Hmm.
it is broad, looks a little
Hmm.
unusual. And then
Yeah.
what about the fact that you have a
Yeah,
waveform?
the same sort of elbow kind of broad response. So, right, it's not
Yeah.
clear that that's.
I right. I wasn't convinced that that
I
was
would not. Yeah, you're right. I'm not convinced now that I look at it, and I would want to see what they saw in the individual
yeah.
studies before they averaged it to see if that was really one response or.
Yep. Yep. Exactly. Okay. Good. So then we went to the ulnar motor.
Mhm.
So here's the ulnar motor.
Yeah, and here we have a normal amplitude, and we did wrist below elbow and above elbow, and no drop in amplitude, so no signs of conduction block. There isn't any. There's the velocity is a little slow, but it doesn't look like it's focally slow across the elbow. So it doesn't really fit with an ulnar neuropathy at the elbow. But again, the distal latency here is long. It's 4.7.
Yeah. Yep. Okay. We'll keep going here. Ulnar F waves look good.
Okay.
And then we did ulnar anti. So you think that's real?
Yeah, I think that's probably,
Yeah, me too.
yeah. So here we have a low amplitude and again a long latency,
Mhm.
normal velocity.
Yeah, and I think the point, with her Searle being sort of borderline for her age, but these are clearly median and ulnar are clearly abnormal. But again, she's had surgeries, so we don't know is that from surgery, residual, or
Right.
so. Okay.
Those
Couple
are
more.
all good points. And now we have the median motor. So here we had the median anti. We weren't convinced there's any response there, but the median motor shows a long latency, slightly slowed conduction velocity. Again, this could be in keeping what we're seeing more diffusely as a process affecting the distal motor endings, or this could be what you might see. This could be like a severe carpal tunnel
Mhm.
where the median anti is gone, the motor distal latency is prolonged, you still have a preserved amplitude, the conduction slowing in that setting isn't surprising that there's a little bit of mild conduction slowing.
Okay. And then F waves here. So we were thinking similar to you. We did a lot more in the arm than just two conductions. So
Right. Yep. And
F
that way looks
waves
good.
pretty good there, I think.
Mhm.
And then we did a radial sensory,
Okay.
which is a little low.
Just because that's helpful, I think, with the mononeuropathy question, just to kind of take that part out of it, look at a nerve outside of the areas of prior question of focal nerve compression. And again, this is reduced, I think, fairly, Our normative values are 20, which sometimes I personally think is a little high, but I would say 10 is low.
Mhm. Yep.
I don't know what your feeling
Yeah.
is about that 20, but there's a lot of times I get like an 18 and
Yeah, no, I agree. I mean, I think one of the things in the future is to better define normal values based on age and other factors. But you're right. I think certainly when she's 59, so I'm not going to count that as old.
yeah,
Uh, but I think when people get older, yeah, 10 to 20 might be more reasonable. But
more
I think
unreasonable.
this is
But I agree. For
this.
her
I
age,
agree.
I think this is
Yeah.
low.
Yep. And then the other two conductions, for some reason, there was comparison to the other leg.
Mhm.
So the right fibular,
Is a little bit better in amplitude and almost, well, closer to normal with a very prolonged distal latency. So again, this is like, I
yeah.
would not be able to blame this on the amount of amplitude
Right,
drop.
right.
Sure, I think
Yeah,
is the key point.
right. And the velocity is even slower there,
Yeah.
33. And then I think this was, oh, this just the fibular they did. So fibular, they did do F waves here, and those weren't bad.
Yeah. So they were able to get one. That's good.
So would you do any other conductions on this patient, or is that
Hmm.
kind of where you would stop with the conductions? We didn't, just
Sometimes I would do a blank, but you probably don't need to. I mean, I was just thinking about it. You have a process that's involving, all the sensories are affected. Sometimes if I think we have enough here that looks like we would meet demyelinating criteria based on the prolongation of the distal motor latencies across these many different nerves. But if I was, on the fence, the blink reflex looking at a prolonged R1 latency can also give me one more feature that helps for looking for proximal demyelination.
yeah. Yeah, I was thinking the same thing, but I think as you said, there's enough here. We're seeing prolonged latencies and slowed velocities in every nerve, basically.
Mhm.
So yeah, so there's enough there that looks demyelinating
Right.
or in part demyelinating. So I'm not going to ask what muscles you would do.
Mhm.
But I'll ask you, what do you think the needle exam showed? What
I'm gonna guess that it showed some very mild, long duration motor unit potentials because this has been going on again for a number of years. We thought like maybe the sensory in the legs has been at least 8 years-ish. So I'm gonna guess that there's some mild motor unit neurogenic changes distally in the lower limbs.
okay.
Probably that's about it.
Yeah, I mean, it really was pretty unimpressive. This is the table. We did several muscles distally in the leg up to the vastus,
Mhm.
and then we did some distal and proximal in the arm, and really not much.
Yeah.
Some turns, a little bit of polyphagia in the anterior tibialis, but
Hmm.
I think the fact that it seems, more demyelinating, so you
Hmm.
just have slowing of
And
the,
still very sensory predominant. I mean,
yeah,
I think in terms of the amount of axonal probably involvement.
yeah. So how would you interpret all this? What would you say?
Yeah, I would say there is evidence of a, it's hard. I would just probably wouldn't necessarily based on this just label it as length dependent because it's kind of a generalized. We don't really have a needle that gives us a clear length dependence. Maybe on our exam we do, but EMG wise, it's kind of a diffuse sort of demyelinating sensory and motor peripheral neuropathy with um, predominantly involving the distal nerve segments.
Yeah, I think that's good. That's almost exactly what I
Yeah.
said here.
hmm
Predominant, distally predominant. I
hmm
didn't say length dependent, and I think that's a good point. We don't know, right? You can't really localize it. Could it
hmm
be a radiculoneuropathy? Maybe, but we don't
hmm
have anything proximal either.
Yeah.
So I said, yeah. So primarily demyelinating and some
Yeah, based on the
myelin.
amplitudes distally. Yeah.
Yeah. All right, so I'm glad that we agree with all of this. I would be
hmm
surprised if we didn't, but so now, so what would you do with this if you were now seeing this patient in clinic?
I would probably do monoclonal protein studies. That's
Okay.
my, I mean, I would check for, hemoglobin A1C or some test of diabetes, fasting blood sugar, the B12. We still have a neuropathy, and based on guidelines, we would want to do at least the baseline tests. Given the distal demyelinating component, I would be concerned that the patient could have an IgM monoclonal gammopathy, based on what you're showing me. Other distal predominant demyelinating disorders, it doesn't fit with like a nodopathy, which could be distal and more demyelinating, but the clinical history of so long certainly doesn't seem to fit well with that.
Mhm.
The history of a sensory predominant with some sensory ataxia would fit better with an IgM
Okay.
MAG neuropathy.
And going back, so you're as we've discussed, you're saying this is distally predominant, which I put too. And
Mhm.
that's based on because there was slowing in the conduction velocities too. So
Right. I think that the amount of prolongation of the distal latencies was more out of proportion to the slowing that we saw in the intermediate segments based on the velocities. But it's not uncommon in that disorder to see both, so that would still be high on my list. It doesn't take out other possibilities. I guess TTR amyloid could still be on there, although not as common to see such prolongation, but demyelination and being a mimicker of CIDP is certainly reported in the literature for that. Um, the amount of slowing distally versus the conduction velocity would seem less likely that this represented a primary demyelinating CMT1A. Usually the conduction velocities in that are much slower
mhm. Okay.
in the upper limb, because I don't think anything in the upper limb was, less than 30
Mhm. Right.
or
And you're basing again, I'm going to harp on this distal
yeah.
demyelination. You're basing it sort of on eyeballing it, on how on the degree of prolongation latency relative to what you're seeing with the
Yeah.
you ever use other
Right. So then you can certainly calculate the terminal latency index using the distal distance, the conduction velocity, and the distal latencies. And, the one most reported there would be median, which I think is also important to think about because a lot of times in the protocols, it's an ulnar motor and a median anti. So if you don't do that median motor, you can do a TLI on the ulnar, but I think more of the data is really about the TLI of the median nerve.
I just put up a slide with the formula of the TLI. Do you do this or do you
Yeah,
more?
sometimes we do actually put this in the report even. Yeah.
Yeah.
I think I would say it's a little, I mean, I wouldn't say it's every single person does it every time, but quite a few.
Yeah, I don't use it very often. Maybe I should, and that's because my mind is too simple and I don't like to calculate. I can add and subtract, but I don't like all these formulas where you're dividing the distal latency into one and multiplying it
Mhm.
by blah blah blah. I think that I'm sort of being facetious, and
Right.
there is utility and there's normative data on,
Mhm.
and that's the other problem for my brain that I can never remember what's normal
Right.
the normal cutoff that would tell me that it's more distal. slowing than proximal. So
Yes. And
uh,
I agree. That's a number that isn't that I have to look up each time too.
yeah, probably when I was a lot younger, I could remember all these numbers, but
Yeah.
so
We need the program to just do it for you, right?
yeah, but you mentioned an interesting point when you're going through your differential about the CMT, because that was something that might come to mind here, that this has been slow. It started when she was maybe 50, so a little older.
Mhm.
But you mentioned, I think you said that usually you'll have more proximal slowing rather than distal slowing out of proportion to proximal slowing.
Yeah, I guess it would be more uniform slowing. So
Okay.
it shouldn't be look more distal than the slowing there than it does in the connection velocity versus the F waves absolutely being prolonged. Usually you would see all of those because the slowing being it's a problem, molecular level that it's like throughout the nerve. So you see it, involve all of those equally or
Yeah.
uniformly, I think is kind of what we typically say on the report, uniform slowing.
Yeah. And I'll come back to that in a second, but I'm going to jump around here. This is like jumping brackets,
Yeah.
but so you said you would do a monoclonal
hmm
protein, and what would you be looking for in that? Like what if it?
Yeah, I mean, so our monoclonal protein study, you would do an SPEP and an immunofixation. Ideally, you would do free light chains, and I think it's helpful to do quantitative immunoglobulins. Now, some of that you could do stepwise, right? See first if you just even have a monoclonal protein on the serum protein electrophoresis and immunofixation, and typically you would find an IgM, and more common it's a kappa.
And if you found that, would you do any other testing or?
Yeah, then I would probably, my practice has changed over time, but I would look for anti-myelin associated glycoprotein antibodies.
Mhm.
Um, I think whether those are positive or not, I think the phenotype, when you just get an IgM, it's probably enough. But I think, we do know enough now with MAG that it's worthwhile testing it and seeing what the titer is, very high and very predictive of this type of neuropathy.
Would you ever get, and I'm asking this because we see a lot of referrals where they
Yeah.
screen for everything. Would you ever do a MAG antibody without having done a monoclonal, like if they don't have a monoclonal protein? Is it worth
Hard
doing?
part is there's a lot of false positives with that. So then if you don't have a monoclonal and you have a positive MAG, we've seen it in amyloid and other conditions and things. And so then what does that mean?
Yeah, yeah, I agree. So I was just going to show this one, jump back again. I found
Mhm.
this interesting paper
Mhm.
talking about CMT versus something like IgM and MAG. And there was a study a number of years ago looking at the TLI, and
Mhm.
they basically and they looked at patients with CMT1A and CIDP and anti-MAG, and they did found that there was a discrimination between the TLI and MAG versus
Mhm.
CMT. So there was a significant difference between those two. And they found the TLI and the MAG was 0.21. That was the mean. And on ours, I did calculate it after
Okay.
seeing the paper, and it was 0.24. So it was like right at the borderline. So
Yeah.
that didn't help. But what they did, what's interesting in this paper, they also did some additional statistics and put
Mhm.
this algorithm together to kind of help guide separating out based on conductions. And if the TLI, median TLI was less than 0.26, which ours was, most of those patients had MAG. If it
Mhm.
was borderline, then they looked at the ulnar distal latency, and if it was less than 7.4, most of those patients had MAG too, which are, so
That's
if you
interesting.
follow this
Mhm.
without knowing anything else, this patient would have a MAG, IgM.
And this is interesting because I think, we think about MAG being so distal predominant, but it's important to remember that in these like CMT1As that their slowing is quite profound and they do have really long latencies and really slow conduction velocities. And so, you would see a distal latency in the leg that would be 13, you
Yeah.
know.
Right. Right. Yeah. So, okay. Well, you want to know what came of this patient?
Sure.
So in 2017, she did have an IgM kappa.
hmm
And back then they did a CSF there was some abnormality. I didn't have the results, so I don't know what was abnormal. She was given a diagnosis of CIDP
Hmm.
and treated with IVIG, and there might have been slight improvement initially, but it wasn't sustained.
Okay.
And then she also had MAG, and it was over 100,000 back in 2020. We
Hmm.
repeated it, and it was real high here.
Yeah.
She had been treated with rituximab with twice without improvement, and then she was started on IVIG again, and they weren't giving it to her very frequently. It was every 8 weeks, and she didn't have really much benefit from that. So
So she's in the unfortunate group of people who are don't respond to treatment, which is
yeah,
probably
yeah,
more than most, is probably most maybe don't respond, but
right.
some do, some do.
And in these patients, and I know this is more of an EMG
Hmm.
lessons lab from the lab, but
Yeah.
when you see, just from your experience, when you see these patients, do you treat with IVIG or rituximab or
Yeah, I do. I mean, at my practice too, I used to always give IVIG first, and sometimes I still do try it because I do have patients that have responded to that. And if they just require that, I feel like that's a safer treatment over time. Rituximab, there are concerns about long-term use and immunodeficiencies and risk of infection. And so, depending on the severity, I may like to try that first. But yes, then I have used rituximab in some patients as
and,
well.
and if they're getting worse and
Mhm.
they despite those, do you use anything else? Is there any?
Then I think it's important to, yeah, so there's some new data, right? If they have like the MYD88 mutation, bone marrow biopsy could help. Is it truly Waldenstrom's? If it is Waldenstrom's in the bone marrow, then there's more treatment options out there. Even if they're now just anti-MAG, not Waldenstrom's, but they have the mutation, maybe there's some, studies or even trials you could think about for some of like the ibrutinib and some of those
Yeah,
therapies. But yeah,
yeah,
it gets challenging, and that's where sometimes, depending on how severe, you're pulling in your hematology colleagues, and you have to weigh the risk and benefit of suppressing that
yeah,
IgM, that clone, versus the long-term chemotherapy
right.
side.
And I'm sure you've seen many more patients than I have with this, but the ones I've seen, it often is it's more sensory and it's usually pretty slowly progressive. So
Yeah,
they still function pretty well, unlike some patients with maybe more aggressive CIDP where they're deteriorating a lot faster. I mean, I'm sure there's
I agree.
a spectrum, but
Yep.
I guess
I
that's,
agree. Most are that sensory predominant, large more than small fiber, sensory ataxia, maybe slight weakness of like toe extension or ankle dorsiflexion, but still maintaining pretty good strength there.
yeah, yeah, good. Well, I want to let you know you just won our bracket.
All
You beat
right.
me because you had all the answers and
Oh,
I did when I was seeing the patient
do I
initially.
get $250? So I'm just kidding.
You get $250 of knowledge. How about that?
Yes, I love it.
But this has really been great. I know I thought you would enjoy that case. I know it's
Yeah, that's
the lines of
fantastic.
what you do and see, and I think it's instructive. I mean, I think the instructive points are pay attention to those distal latencies and especially when they're more prolonged than the more proximal conduction. That should key in the things that you mentioned that some of these atypical neuropathies.
Hmm.
Yeah.
Yeah, definitely.
So, well, I appreciate you taking time out of your spring day and
Absolutely. Thanks for having me. It's been a
all
lot of
right,
fun.
it's been great. All right.
All
Take
right.
care.
Bye,
Bye.
Devin.
I hope you enjoyed this episode of Lessons from the Lab. That was really a terrific discussion. It was an interesting case. It's one of those cases of neuropathy that we don't always think about. It's uncommon, but I think the instructive points relate to both the clinical picture of hands before feet symptoms, but more importantly, the features on the electrodiagnostic testing, particularly the demyelinating features in the distal segments of the nerve, should be a clue to identifying patients with IgM gammopathy or anti-MAG antibodies. And even though those aren't the only conditions that can cause that. It's something to be aware of when we're evaluating the patients. So I hope you all enjoyed this. I hope you all won your March Magnus brackets, and I look forward to seeing you next time. Bye bye.